Hello, everyone. I'm Marcia Mott, and welcome to UF Health Wellness University. Thank you so much for joining us today as we discuss erectile dysfunction. I'd like to introduce you to our speaker, Dr. Larry Young. Dr. Young is an associate professor at the University of Florida, and he serves as the medical director for UF Health Urology. He attended the University of Florida for both medical school and his residency, and he completed a fellowship in reconstructive urology at Washington University. UF Health was recently ranked number 17th urology program in the nation by US News and World Report. If you have any questions for our speaker today, you can submit written questions at any time using the Q&A button at the bottom of your screen. I know this topic can be very private, so please feel free to submit your questions anonymously. At the end of the presentation, I will ask all questions anonymously. We will try to get through as many questions as possible today. Dr. Young, I'm going to turn it over to you now. Thank you so much.
Thank you, Marcia. Welcome, everybody. Thank you for joining us today. Just want to make sure my slides showed through okay, Marcia?
Not yet.
Let's see here. Do this. How about now?
That looks perfect.
All right, there we go. All right, welcome everybody. So as Marcia had mentioned, my name is Larry Young, an associate professor in Department of Urology at the University of Florida, and I did my fellowship in reconstructive urology and also specialized in prosthetics, which is essentially surgery to implant prosthetic devices to correct certain problems like erectile dysfunction, urinary leakage, are probably the two main issues that I mainly treat. And then a lot of my practice revolves around cancer survivorship, which means I help to try to improve the quality of life for patients who have suffered some damage in any form to the urinary tract, whether it be from the kidneys all the way down to the external genitalia, as a result of either surgery or radiation therapy that has diminish their quality of life. And so there are certain medical and surgical options that I can offer to help to try to improve upon these patients' quality of life. And one small area of concentration and expertise is in erectile dysfunction. And that's what I'm going to talk and concentrate on today. Also on the slide here is the phone number for the clinic. And it'll also be on the last slide. And I think that this talk is also recorded, and Marcia has that phone number for our clinic if anybody wants to make an appointment to be seen to further discuss things in person. So what is erectile dysfunction? Well, the National Institutes of Health has defined erectile dysfunction to specifically mean the inability to maintain an erection that is firm enough to penetrate for sexual intercourse. This is a very common problem in men, and it is probably well underreported because many men are embarrassed or ashamed to present to their primary care physicians or even their urologists that they usually see on a routine basis for this specific issue. There have been studies that have sent out surveys to men to try to determine how common this problem is, and we kind of think that it's somewhere around 10%. So about 1 in 10 men has erectile dysfunction, which equates to over 30 million American men. About 90% of the time, erectile dysfunction can be attributed to some physiological problem. And I'll get into more detail about the physiology later, but that essentially means that there's some problem either with a hormone imbalance or some issue with blood flow. And then the rest of 10% of the patients or so has some psychological barrier to erectile function. And so that could be things like stress or anxiety, whether it be related to marital problems or social situation or stress at work, at home. Things like that can certainly impact negatively on one's erectile function. But I would say the vast majority of men probably has a combination of both a physiological component as well as a psychological component, because the inability to achieve an erection, if it is due to some physiological problem, ultimately results in some psychological distress to the man. And so it's essentially a snowball effect that leads to this problem. So what are some of these physiological problems? Well, so diabetes is probably one of the most common diagnoses that I see. So diabetes is a medical condition that causes global dysfunction in the body. So that means that it affects essentially every organ system in your body, from your eyes all the way down to your toes. Patients with uncontrolled diabetes can go blind from problems with circulation to the microvascularity supplying the eyeball, all the way down to the little micro vessels supplying the circulation to your toes. And so some patients with uncontrolled diabetes have to have toe amputations because of poor blood flow to the toes. That same concept applies to the microvasculature supplying the blood to the penile area to allow a man to have an erection. And so these blood vessels become destroyed through uncontrolled diabetes, which then prevents adequate blood flow into the penis. Diabetes also destroys nerves, the blood flow to the nerves. And so if the nerves are no longer functional, that the nerve signal that goes from the brain to the tissues in the penis is no longer there, and the erection cannot occur, and hormones that are released from the nerve endings are just not there to allow the erection to occur. And so this is a multifactorial problem, meaning that diabetes affects not only the circulation, but it also affects the nerve function as well. Heart disease is also a very common cause for erectile dysfunction. Men who have erectile dysfunction typically have heart disease. I also see young men with heart disease in their 40s. And one of the first things I do is tell those patients, if they have not already been evaluated by their primary care physician or a cardiologist, that they need to go in to see them to potentially be screened for heart disease. Again, these blood vessels that supply the penis are very, very small vessels. They're even smaller than the ones that supply the heart. And so if somebody is suffering from a heart attack due to blocked vessels from plaques within their arteries, they probably have that same problem going on in the smaller blood vessels that supply the blood to the penis that allows the erection to occur. Surgery to the pelvic region, the penis, anywhere down in the vicinity of where those nerves course down into the area of the genitals can also cause erectile dysfunction. And so it's very common for men who have prostate cancer to have the nerves damaged through the removal of the prostate. Some men choose the radiation therapy route for prostate cancer, and that radiation therapy is delivered right to the prostate, and the nerves basically sit on top of the prostate capsule. And so when somebody has radiation therapy for prostate cancer, the cancer cells are killed within the prostate, but unfortunately, the nerves that allow the erections to occur are innocent bystanders to the therapy, and the nerves eventually become damaged along with the blood vessels. And so men who undergo radiation therapy for prostate cancer can develop erectile dysfunction that is usually a gradual worsening over time, as opposed to somebody who underwent surgery to remove their prostate, where when you come out of surgery from prostate cancer removal through a prostatectomy, some patients end up with immediate erectile dysfunction after that type of surgery. Same thing goes with bladder cancer. Patients who have their bladders removed for bladder cancer, the nerves are right underneath the bladder, which is where the prostate sits, and those nerves become damaged through that type of surgery. And the same goes for patients with colon and rectal cancer. The prostate, again, is an organ in the deep pelvis, and for some patients who have colon cancer or rectal cancer, the prostate sits directly on top of those organs. And so those nerves, again, and the blood vessels become innocent bystanders to therapy to remove these cancers. Medications are also a very common cause for erectile dysfunction. One of the most common classes of medications that I see patients come in on are antidepressants, and the class is the selective serotonin reuptake inhibitors, or the SSRI medications. And so these medications are notorious for causing erectile dysfunction or lower sex drive. And in fact, some of these classes of the SSRIs are used to treat men who have basically an opposite condition, or premature ejaculation, where they orgasm too soon, one of the side effects that was seen with this class of medications was that it essentially suppressed or decreased the, increased the length of time that it took for a man to be able to achieve orgasm. And so for that subset of men with the problem with premature ejaculation, these antidepressants can be prescribed. But in some men, that effect of the SSRIs is actually too strong, and it actually can, like I said, cause problems with low sex drive, inability to achieve orgasm, and even erectile dysfunction. For some men who've had either surgery on their spine for some spinal problem, or they had some accident that led to some spinal cord injury, those nerve signals that course from the brain down to the organs down in the pelvis can become disrupted, and that can lead to erectile dysfunction as well. Hormone imbalance is also something that we typically screen for in somebody who comes in with erectile dysfunction, especially if they're in an age group where you typically would not expect that to occur, such as somebody in their 30s or 40s. We would classically screen for a hormone imbalance such as low testosterone. This slide just goes over the risk association between heart disease and erectile dysfunction. Like I talked about earlier, the coronary artery disease is a risk factor that is associated with erectile dysfunction. And again, if you are a young person with erectile dysfunction, you should probably be screened for coronary artery disease. All right, so I'm going to spend the rest of this talk kind of going over the different treatment options that I classically will talk to somebody who comes in for a consultation for erectile dysfunction. And so kind of going from the least invasive down to the most invasive therapy available, these 6 bullet points kind of summarizes what we're going to talk about here. So briefly, the first bullet point is low testosterone. So again, the hormone imbalance, if you're screened for testosterone deficiency and you're found to have low testosterone, one option is to try to consider putting you on testosterone replacement therapy. Now, that being said, there are many studies out there that show that even if you have erectile dysfunction and you are placed on testosterone replacement therapy to get you into a normal testosterone range, that may not be sufficient to allow you to have normal erections, because the erectile function, it requires multiple things to work in concert in order for that erection to occur. And so you have to have, I'm sorry, I'm about to be disrupted here.
Okay, thank you, sir.
I apologize. All right, sorry. So what was I? Testosterone. So yeah, so even if your testosterone is replaced back to normal, your erectile function may not go back to normal, because you may have some other concomitant problems such as uncontrolled diabetes, high blood pressure, or problems with your cholesterol that may lead to the inability for that blood to get down to the penile region. Vacuum erection devices is the next thing on the list. And so that's an option for men who have erectile dysfunction, who want to choose a more non-invasive method to restore your erections. And so I'll go into more detail that in the next few slides. The next options in terms of order of invasiveness would be oral medications. And this is a class of medications known as the phosphodiesterase 5 inhibitors, or the PDE5 inhibitors. And these are the ones that you may have been familiar with through commercials and whatnot, but these are the Viagra, Cialis, Levitras, and Stendras on the market. And those are actually the 4 medications on the US market currently. We'll talk about injection therapy. We'll talk about urethral suppositories, and then the end of the road treatment option, which is the surgical therapy, would be the penile implants. Some of these therapies are more satisfying than others. Oral medications have been found to be ineffective in up to 30% of cases, and that could be for a multitude of reasons. It could be inadequate administration or taking of the medication. Some medications have to be taken on an empty stomach. Some medications have to be taken a certain amount of time away from when you plan on having sexual activity. And so there are different reasons why it can be ineffective, but it could also just be that the blood vessels are too obstructed from some physiological condition, and so you just physically can't get the blood down to the end organ, which is the penis. Vacuum erection devices can be cumbersome, can be unromantic, and I'll go over that a little bit more in the next slides. Injection therapy requires needles, and you're actually injecting yourself with a small needle. The injection can cause some burning in the penis, and because you're actually injecting the needle into the tissues of the penis, there's the chance to cause some long-term scarring in the body of the penis, which can potentially cause some disfiguring of the penis as well. Urethral suppositories, they can be very expensive. They can cause pain and burning within the penis in up to 30% of patients. And so this is a slide that goes over the vacuum erection device. So when I talk to men about their different treatment options, I typically start with discussing the vacuum erection device. It is a highly effective device, and essentially what it is a vacuum chamber, like you see in the little cartoon drawing here, that you put your penis in, and there's a tube that's attached to the end of this chamber, and there's some device, whether it be a mechanical pump or a battery-powered pump, that actually suctions the air out of that chamber. When the air is evacuated from the chamber, the blood then fills the body of the penis, and the penis basically engorges and fills that chamber. And then that red band that you see at the bottom of the cylinder is essentially a tight silicone band that is placed down to the base of the penis to hold the blood within the penis until you're completed with intercourse. The benefit is that it is a non-invasive technique to allow a man to have an erection. It is 100% reversible. Medicare used to cover this device up until about, I would say about 5 years ago or so. The cost it's relatively accessible for many patients, depending on the model that you choose. The manual pumps, where you're actually having to physically pump a bulb to get the air out of the cylinder, are cheaper than the ones that are battery powered. And the price ranges, I think, are anywhere from $200 to $500 or $600, depending on the model that you choose. So, you know, it's a reversible option. So you can always choose to try it. And if it works, great. And if it doesn't, then you just throw it aside and move on to the next therapy. Intracavernous injections are the next option in terms of order of invasiveness. So besides the pills, being the Viagra, the Cialis, and the Stendras, this therapy is going to be the most effective option to allow a man to have an erection when they can't have one normally or without the aid of medication. And so, just like this cartoon shows, you take a 1 milliliter insulin syringe with a very small, either 29 or 30 gauge needle, and you actually inject it into the side of the penis. And the tip of the needle has to get into this pink tissue, which is what we call the erectile tissue. And these are sinusoids, or little sinuses that fill with blood during an erection. And that's how the penis becomes engorged. And so through this injection, you're actually delivering this medication directly into the body of the penis. And that medication then circulates locally and throughout the tissues, allows the blood to come into the penis, and allows the man to have an erection. It is very successful, and more so than the pills, because with the pills, you have to wait on absorption through the GI tract to then get the medication to the bloodstream. But then once the medication's in the bloodstream, you still have to have adequate blood flow to the penis in order to get the medication directly to the tissues. With the self-injection of the medication, you're bypassing that whole process of the absorption of the medication and then circulation to the tissues. Here, you're actually directly injecting the medication into the penis itself, where the medication can take place locally or take effect locally. And so up at the top of the screen, you see the different names of compounds that we can classically prescribe. And so the first couple are these single agent medications, being the Caverject and Edex, as well as the phentolamine. And so that means that there's only a single medication in the mixture that is injected into the penis. Then there's Trimix, and that's papaverine, phentolamine, and alprostadil. And so those are 3 medications. So it's a combination of 3 medications that work in 3 different mechanisms of action to allow blood to rush into the penis, but then also collapse the veins down to prevent the outflow of blood from the penis. And if the trimix doesn't work, then the quad mix it would be the next option. That's essentially adding atropine to the mix to create a stronger formulation. And studies have shown that men who choose intracavernous injections have an 80+% success rate. In my experience, I think it's even higher. It's probably 90+% of men who choose this option can have a satisfactory erection using their own normal blood flow mechanisms, assuming that you still have the ability to get blood into the penis. The cons, obviously, you're injecting yourself with a small little needle. And so you kind of have to get over that hurdle, the mental hurdle of being able to inject yourself with a small needle. What I find is that patients who are diabetics who typically inject insulin in themselves tend to accept this therapy more than those who are not diabetics or don't have to inject themselves in the needle for some other medical condition anyway. But even men who don't use needles normally for medication injection kind of get over that fear of the needle, especially when we bring them in for the training session to teach them how to do the injections correctly. And I think that's the critical part of this therapy, is this trying to walk patients through, helping them understand what they're doing and why they're doing it, and to avoid the problem areas where you can potentially cause some injury to the penis. And so that's this drawing here is a cross section of the penis, and the blue little ovals here denote where some of the veins on the penis are. And then the circles that you see here on the cartoon, the red circles, are the arteries that are above the erectile tissue. And those are where some of the main blood supply to supply the tissues outside of the erectile tissue are located. So, we tell you to avoid that area. We also tell you to avoid the urethra, which is this other oval at the bottom of the penis. That's your urine channel. So obviously you don't want to stick the needle into the urine channel. And so we have a whole training session. We give you the instructions. You go home and read about it for probably a couple of weeks until your next appointment, when you come in and we actually inject a sample of the medication directly into the penis. The other issue is this issue of priapism. And so that's the medical term for an erection that lasts longer than 4 hours that won't go away. You probably hear about that with the Viagra and Cialis type medications. Well, that priapism risk is actually higher with this medication because it works so well. So priapism, when it occurs after an injection, essentially is an overdose of the medication. And so that's why it is very important to go through this training session to basically teach you how to self-titrate the medication. So you're starting with a very, very low dose of the medication at home. It's probably initially going to be actually an ineffective dose. The dose is too small to allow you to have a full erection. And so then you will gradually, over time, with each session, learn how much medication your own body needs in order to achieve a full erection. And so you probably start with what we will call 5 units, which is a very small amount. And the next time, if 5 units doesn't work, then you'd go to 10 units of the medication, and you just titrate to the effect that you're looking for. And so this injection has to be done probably about 5 to 10 minutes prior to intercourse. Afterwards, you will have blood rush in. You will get an erection, regardless if you are sexually stimulated or not, unlike the oral medications where you do require sexual stimulation in order to achieve an erection. So if you take Viagra or Cialis, it's not like you're going to walk around for 24 to 72 hours with an erection. You do need to be sexually stimulated in order to achieve an erection. Well, the converse is true for the injection therapy. If you inject yourself in 5 or 10 minutes, assuming you respond to the medication, you will have an erection. And you want to try to titrate it to, I tell patients, 30 minutes to an hour or so. If the erection won't go away with this injection therapy, this does become an emergent problem where you will, depending on the time of the day, either need to go to the urology clinic or you'll have to go to the emergency room if it's after hours. Because if the erection doesn't go away, you will need to have essentially an antidote injected into the penis, or it's a reversal medication that opens up the blood vessels to allow the old blood to rush out of the penis and then fresh blood to come in to replace that old blood. If you don't go to the emergency room to get this addressed, what happens is the old blood stays in the penis. That old blood loses oxygen content. It essentially becomes deoxygenated blood, and that the tissues inside the penis essentially start to die from lack of oxygen, from lack of fresh blood flow. So that's why this is nothing to kid around with. This is definitely an emergent problem if it happens. But in the literature, the reported rates of priapism are around 10%. But in our clinic here, it's pretty rare that we have a patient that presents with a priapism, especially after they've gone through the appropriate training sessions in the clinic. Intraurethral suppositories is the next option on the list. And so what this is this little applicator that deposits this small pellet that is in green in the cartoon here, which is the size of a grain of rice, into the urine channel. And this is just another method to deliver medication directly into the tissues locally, into the penis, while bypassing the systemic circulation. So again, we don't have to rely on you taking a pill, absorbing it through the stomach, and then getting into the bloodstream, and then going through the blood vessels to the tissues. The pill dissolves into the tissues locally, and it acts very similarly to the injectable medications. The downside to this is there are only certain insurance carriers who will actually cover this, and it's pretty few and far between. And they can cost, depending upon the dose of medication that you require, anywhere between $30 to $90 is what I've been told per pill each time you want to have an erection. It is effective, but not as effective as the injections. Studies have shown up to 65% efficacy. But the other downside to this is this phenomenon of penile pain. And so men who have tried this, they've described this pain in their penis as almost like a migraine headache in their penis. It's this throbbing sensation. And that's just the side effect of this medication and what it does when the blood vessels dilate to allow the blood to rush in. And so the last treatment option on the list is the penile implant. And so this is a study that was done by Dr. Dabwala, where they surveyed patients who underwent a penile implant and then compared that to how they felt when they were on oral medications or penile injections. And so you can see here from the bar graph, penile implant ended up with the highest satisfaction rates, followed by oral medications at 51%, and then penile injections at 40%. And so penile implants is, when I tell patients, kind of the end of the road treatment option. This is an irreversible option, meaning you can't say, well, I want to try the penile implant. If I don't like it, then let me try the medications or the injections. Unfortunately, once you choose to have a penile implant placed, that's it. You can't go backwards. And the reason why is because through surgery, we are actually implanting this prosthetic device, which I'll show you in the next few slides. And that device actually displaces your normal tissue that allows you to have an erection. It displaces those two pink cylinders, which is where the erectile tissue is. And once that tissue has been displaced, if you take out the device, that tissue is no longer there to engorge the penis. And so that's why I tell patients that you want to make sure that this is absolutely the option that you want to pursue. And you want to probably consider exhausting your medical options before you go to this end of the road option. Now, that being said, again, as you can see in the previous slide, the studies show that the highest satisfaction rates are with the implant. And so if you come in and say, I've done all my research, I know about all the other options, I know about the injections, I know about the pills, I want the implant, you're free to choose what option you want, as long as you understand all the potential ramifications of going with an implant right off the bat. And that being said, the penile implant has been around for over 30 years. Now there are about 25,000 penile implants being placed per year, with over, this is a several-year-old slide now, there's probably over 500,000 implants have been done to date now. with very high patient and partner satisfaction. And so this next picture here shows the different types of implants that we have available to implant, from the one-piece non-inflatable device, which is essentially a silicone sheath with a wire scaffold in the middle. And when you want an erection, you bend the penis up. And when you're done, you essentially bend the penis down, just like it shows in the picture. There's no fluid to shift. There's essentially nothing to malfunction, nothing that really can break unless you, I guess, wear the wire out in the middle. But I've never seen anybody wear one of these one-piece devices out. The downside of the one-piece is that it is constantly erect, essentially. So your penis is always going to be on stretch. You're just essentially changing the angle of the penis from up to down by bending the internal wire. There's two-piece inflatable devices, and then there's three-piece inflatable devices. And I'll go over those into more detail later here. And so again, this is a slide going over the one-piece device. I rarely put this device in. I really only would consider putting this in somebody who really wanted a penile implant, but they had problems with manual dexterity, meaning you had some medical condition, usually some arthritis condition, where you just could not grasp a pump to actually operate it to shift the fluid, which we'll talk about in the next couple slides. And so if all you could do was essentially change the angle of the penis, this could be an option for men who choose an implant but can't operate a pump. And again, the downsides are that it still appears firm even when it's not in an erect position. And there's the potential to show through your clothing. You might see a bulge down there because this, again, implant is constantly expanding the penis. The two-piece inflatable implant is kind of a step up from the one-piece, although not a great step up. This is one that I, again, rarely place as well. This is one that for somebody who does not want the constant inflation of the one-piece device, and they still want the ability to have a somewhat flaccid penis after it's deflated, but they just don't have the space to put the reservoir that's required for the three-piece device that I'll describe, because they've had some abdominal surgery or skin graft or some trauma to the abdomen or pelvis that would prevent me from being able to place that reservoir for the three-piece device. It doesn't deflate as well as the three-piece device, and it also doesn't really inflate as well as the three-piece or even one-piece device. And so I maybe will put this in once or twice a year, but I don't like doing this. And so I'm not going to spend too much time about talking about the two-piece device. So the three-piece device is actually the best one out of all the types of implants. And in this picture, what you can see here is the three pieces are the cylinders. So there are two pink circles in the penis. Those are the corporal bodies that fill with that, well, they used to fill with blood, now being replaced by the silicone cylinders here. So there's cylinders in the penis. The secondary component is the pump in the scrotum. And then the third component is this fluid reservoir that gets hidden up next to your bladder above the pubic bone. All the components are hidden underneath the skin. Nothing is visible externally. You might see maybe a little bit of a shape of a tube if you have thin skin. This pump goes down into the scrotum, kind of in between your two testicles. But if you were to just stand there, you really couldn't tell that you had any prosthetic device in place. This acts and feels more like a natural erection as compared to the one in the two-piece device. In some, I guess, iterations of this device, they can slightly expand the girth of the penis. The length of the cylinders can expand somewhat, but the length of the penis is not going to get larger than the physical constraints of the tissues. So it's not like, don't expect to have a larger penis after this. You're just going to be able to have the ability to have an on-demand erection. The other advantage is that when it's fully deflated, your penis looks like a completely normal flaccid penis. And so This is the implant that allows you to have the most natural penis in an erect and flaccid state. The disadvantages is that you do need to have adequate manual dexterity. You have to be able to operate this pump. You have to be able to feel the pump. So you can see here, this pump has little knobs or these little rectangles all over it. That just provides texture to the pump so you can actually find and feel the pump. And then the circle above is the deflation mechanism. This is just one iteration of this pump. There are different types of pumps available, but this is one where there's a circle. And so you push on the deflation button, which then allows the fluid to go back into the cylinders. These devices have high mechanical reliability. They're designed for long-term dependability. And on average, a man can expect to have about 10 to 15 years of life out of one of these devices. Now, it is a mechanical device. There are valves within. This is there's tubing that connects these saline covered cylinders. And so if something breaks, it's usually a crack in the tubing, which results in a loss of the fluid, which is just simple salt water. And so if you have a break and a leak in the system, the fluid that comes out is non-toxic. It's just salt water that kind of diffuses into your body. I have seen patients that have had their implants for over 20 years. I've also seen failures occur as soon as 1 year after surgery. This is variable. Again, it's kind of like your vehicle. The more you drive it, the more you use it, the sooner it's probably going to fail. You might buy a lemon vehicle and it breaks down in 6 months, or you might get a good vehicle and you never have to do anything but change the oil every 10 or 1 year, and you drive it for 10 years without any problems at all. Again, high satisfaction rate at 3 years with the three-piece penile prosthesis has been shown. That was with that study, over 90% satisfaction rate. And so there was another study that was done, and whether or not patients who had a penile prosthesis placed would recommend it to others. 92% said they would. And then 90% of the partners who had implants done said that they would recommend that their partners consider having an implant placed. It allows you to achieve and maintain an erection easily. It's an automatic guaranteed erection. So it's an on-demand. Again, you basically on-off, you pump it up when you want an erection. When you're done, you hit the deflation button. You'll achieve an erection that's hard enough for penetration, that allows you to have sexual intercourse, and it's dependable and it works every time. Now, the one caveat to this is that I would mention is that if somebody has very poor erectile function and the head of their penis does not engorge during sexual arousal, the head of the penis will still remain floppy and flaccid during an erection, even after an implant is placed. And that's because the cylinder, so the head of the penis is actually a separate structure. It's almost like a cap on the shaft of the penis. And so when we put these prosthetic cylinders in, it's supporting the shaft of the penis, but there's no prosthesis that goes into the head of the penis. And so essentially the head of the penis is being supported by the rigid tip of the penis. And so occasionally I'll see somebody come in that had an implant placed somewhere else and they weren't counseled appropriately. And they say, well, why is the head of my penis not firm when I pump this thing up? And I have to explain that, there's no implant at the head of the penis. It's the shaft of the penis that's firm, that's supporting the essentially flaccid or floppy head of the penis. The other downsides to the implant, like we talked about briefly before, is that this obviously requires surgery to put in the device. If you have a failure of the device, whether it be at 6 months or 6 years, if something breaks, tubing cracks, or for some reason the pump doesn't work, unfortunately, you do have to have surgery to repair, take out, and either diagnose what the problem is, and we either fix a problem if it's an early break, and we can just kind of pinpoint and troubleshoot the problem and change out that part of the whole device. If the device is usually over 4 to 5 years old, I'll just go ahead and change everything out at that time, just because of the age of the device. Again, it's non-reversible. If you choose that you want to have the surgery, you can't go back and say, well, I don't like this, let me go back and try the oral medications or the injections. And some men can complain of some discomfort from pain or use of the device because you are having to grab the scrotum. The pump is underneath the skin. And depending on your body habitus, some men may have a more difficult time than other men in operating this device. And if you can't physically see your scrotum, that can become or pose an issue in operation of the device if you're accidentally grabbing your testicle instead of the pump itself. And that can potentially lead to discomfort in trying to pump up the device itself. So in summary, erectile dysfunction is a very common problem, but fortunately, nearly every man can be successfully treated for their erectile dysfunction. Medical therapy can be reliable and a non-invasive solution for erectile dysfunction. But if that fails, penile implants do offer a dependable and long-term solution. And so if you're in this camp where you're suffering poor quality of life because of erectile dysfunction, please talk to your partner, talk to your urologist. We certainly have options available to correct the problem. Thank you. We have some time to field any questions that you all may have.
Yeah, I'm gonna have you stop sharing your screen in a second here, and I'm gonna go ahead and ask one of the questions that we received. Someone wants to know, what is the role of age in erectile dysfunction? I know you touched upon that a little bit, but I'm kind of wondering if you could talk about that a little bit more.
Yeah, so age, so through the normal aging process, it's not so much age itself that can lead to erectile dysfunction, because I see men who are 90 who have completely normal erections, but I also see 18-year-old men who can't get erections either. And so again, erectile function is a multifactorial, erectile dysfunction is a multifactorial problem. And typically erectile dysfunction that comes on with age is associated with the other comorbidities that come along with age, such as potential for diabetes to occur, high blood pressure, high cholesterol, low testosterone. Those issues, as you age, when they become a problem, if they become a problem, are usually the contributing factors to erectile dysfunction. Now, if somebody comes in who's younger, again, like 18, 20, 30s even, then it's typically either a purely psychological barrier to erectile function, or there's truly some hormonal imbalance, some problem with testosterone, or some other complex endocrinologic problem that needs to be evaluated to figure out why that young person cannot get an erection.
Okay, thank you very much. We've got a couple questions about implants, and someone says, when an implant fails, is it automatically you're going to have another surgery? And then do you do that surgery outpatient by chance?
Yeah, so if an implant does fail, unfortunately, it does require surgery to repair the device. Failures typically are due to a crack in the system, either a puncture in the cylinder or a break in the tubing. And what happens when that occurs is essentially you have a loss of fluid from the system. And I can almost immediately diagnose what the problem is on examination. And these typically require an exam in the clinic to figure out what the problem is. But sometimes I can't tell what the problem is, and I won't know until we get in the operating room and open the tissue up to diagnose what the problem is.
Okay. And then are penile implants covered by Medicare? And then do you have to stay in the hospital overnight if you're receiving one?
Yes, so penile implants are covered by Medicare. They're also covered by private insurance carriers. The only carrier that does not cover penile implants is Medicaid. Surgery for penile implants, at least in our institution, is typically what we call a 23-hour observation. And the reason why we do that here is to minimize the risk of the collection of blood in the scrotal region that can lead to potential infection. And so we keep the patients overnight with a drain into the scrotum, and then we let them out the next morning, pull the drain out before they go home.
Okay. Here's a question about some medications. Is it possible that Cialis could be a benefit against heart disease or stroke if you are taking it for erectile dysfunction already?
I am unaware of any evidence that shows that it is protective against heart disease. So no, I don't think that trying to take Cialis for your
All
heart
right.
condition is warranted.
Okay. Are there any medications like Cialis or Viagra that have fewer side effects than others?
It's a good question. I don't have that slide in this talk, but so the differences between those four medications, Cialis, Viagra, Levitra, Stendra, is essentially the pharmacokinetics. What that means is how long does it take to take effect in your body? And so some of them act more rapidly, such as Stendra. And I think the Stendra acts within, I want to say 30 minutes of ingestion, 15 to 30 minutes of ingestion. Some take longer, like Cialis. I think it's within an hour. They recommend taking it at least an hour before intercourse. But then the other part is how long does it last in your bloodstream? So Cialis tends to last the longest. And so that's the pill that they advertise as the weekender pill. So it can last up to 72 hours in the bloodstream. And so patients can take it on a Friday and they're covered for Friday, Saturday, Sunday, potentially. Whereas other medications have a much shorter, what we call half-life, meaning it basically washes out of your bloodstream much faster. So Viagra, I think, has a half-life of around, 6 or 8 hours. And so it washes out of your bloodstream much faster than the Cialis. And so you have to take it more frequently. So Viagra, if you basically have to take it on demand, and you could take it pretty much every 24 hours, I guess, if you needed it that frequently. But those are essentially the differences between those medications.
Okay. I got a couple questions about a sonic wave or a wave treatment. Do you have any opinion of that? And then someone also said that they have tried it without success. So I want to know if you could discuss that a little bit.
Yeah, so there have been some studies looking at this, what we call extracorporeal shock wave therapy, and there are different brands of this therapy out on the market. There's kind of conflicting evidence as to whether or not it actually works, but the biggest problem is that we don't really have any clue as to how many times you need to have this done, how frequently should you have this done, and what the energy settings for this device needs to be. And so we don't do that here at the University of Florida. I know other urology practices do advertise that, but I do caution you because usually these therapies require some monetary outlay that is not covered by insurance, and the evidence just does not back it up. And so it's not considered a mainstay therapy or mainstream therapy for erectile dysfunction. And at this point in time, it would be considered purely an experimental type of therapy. And if you're willing to experiment, then that's up to you to decide.
Okay. So talking about some things that maybe aren't mainstream, I got a question about, are there any natural solutions or things that are like an herbal supplement or anything like that that could help?
That's a good question. So unfortunately, there is nothing natural or so-called natural that will allow you to have restoration or erectile dysfunction. I actually just recently came across an article about some of these advertised homeopathic remedies for erectile dysfunction. And when they actually studied the compound of those medications or those herbal supplements, they actually were basically laced with generic versions of Viagra and Cialis. And so essentially you're just taking Viagra and Cialis and they're just marketing it as a very expensive homeopathic remedy. And you probably could just get the generic versions of Viagra and Cialis at a much cheaper cost.
Okay, good to know. Thank you for addressing that. Someone had a question about normal testosterone levels at maybe age 40. And then when would you start testosterone therapy? Could you talk about that a little more?
So can you repeat the first part of the question again?
Yeah, what is a normal testosterone level for a 40-year-old? And then when would you start considering treating that?
Yeah, it's a good question as well. So there is no set normal values for certain age groups. There is a normal range, and the normal range varies from lab to lab depending on where you have the blood drawn. So one lab's low end of normal could be 200, whereas the next lab's could be 350. And so if you're going to get your testosterone checked, and we usually check it twice to confirm whether or not the first level was truly low or not. You want to make sure that you have it drawn at the same lab at the same time of day, which should be done between 8 and 9 o'clock in the morning. And so, somebody who's age 40, they should have a somewhat normal testosterone level. So if you have it drawn at the correct time of day, early in the morning, 8 a.m., your testosterone level should be at least in the 300 to 400 range at a minimum. And even if you are at the low end of normal, if you're not having any symptoms, that's not something we would jump on and talk about treating unless you were having problems, because there are potential long-term ramifications to long-term or any testosterone replacement therapy. There are FDA black box warnings out there that have described the studies have shown that patients who are on testosterone replacement therapy have the potential for increased risk for cardiovascular events like blood clots, heart attacks, and strokes. And so it's not like taking a vitamin C pill if you have low testosterone. It requires very intensive blood work monitoring every 3 to 6 months. And there are real potential side effects for testosterone replacement therapy. And testosterone therapy is also a very controlled substance. It's in the same class of medications like narcotics, like oxycodone and the likes. So it's very controlled.
Okay. We got a couple questions that kind of came in that really, I'm going to summarize them as like, how do I begin this journey? So maybe I've talked with my primary care doctor, and maybe I've tried a medication as a solution. When do I decide what is that next step to come and see someone like you, for instance?
That next step is as soon as it crosses your mind, because we have options available. And if your primary care physician is uncomfortable treating it, or they have put you on oral medications and that's ineffective, we have a team of urologists here who are willing and able to address the issue and talk about your different options available based upon where you are in your journey. Okay. Again, this is certainly something that, don't be ashamed to address this, to talk about it. We have options. It is a very common problem. It's even more common than what's reported in the literature.
I'm sure. Yeah. I got one more question that came in. I've had surgery for Peyronies disease. Would that affect my ability to have an implant?
Depends on the type of surgery you've had. So Peyronies surgery could be as simple as kind of bunching up the tissue on one side, or it could involve cutting out scar and putting graft tissue in the penis. And so that would kind of have to be individualized based upon that patient's situation. But for the most part, surgical procedures for correction of Peyronies disease, which is a condition where a man can have curvature to their penis because of scar tissue, usually does not prevent them from being a candidate for a penile implant.
Okay. All right. Well, I don't have any more questions out there this morning. I want to thank you so much for your time and really talking about this very important subject. And thank you so much for joining us today.
Thank you. Thanks for having me.
Okay. Thank you.